We designed appropriate empiric therapy for HAP and VAP, and we de-escalated from empiric therapy to pathogen-directed therapy. We also evaluated patients' clinical stability to switch from IV to PO and recommended appropriate duration of therapy for HAP and VAP. Now let's develop a patient-specific plan for prevention of pneumonia. When it comes to the prevention of pneumonia, the older 2007 IDSA guidelines has several recommendations. Of course, influenza can lead to secondary bacterial pneumonia, so influenza vaccine is recommended, as well as pneumococcal vaccine, which I will discuss shortly. Now, for patients who are hospitalized, vaccination can actually be performed at discharge prior to patients going home, and of course, it can also happen in the outpatient setting. Smoking is a risk factor for pneumonia, so smoking cessation is very important in preventing community-acquired pneumonia. And those who continue to smoke, influenza and pneumococcal vaccination is really important for them. And of course, respiratory hygiene, including washing hands, is really important in preventing spread of germs. The new 2019 IDSA guidelines did not make any new recommendations for prevention of pneumonia. Now, before we talk about pneumococcal vaccines, it's important to distinguish between pneumococcal disease and meningococcal disease. So when people talk about pneumococcal disease, in general, they are referring to pneumococcal pneumonia or pneumococcal meningitis, which are caused by the organism Streptococcus pneumoniae, which is a gram-positive coccus. Now, this organism Streptococcus pneumoniae does have an outer capsule that's composed of polysaccharides, and because there is variation in this polysaccharide, there are more than 100 serotypes that are known. So the vaccines that we have are targeted at different serotypes. In general, we have two types of pneumococcal vaccines. We have pneumococcal polysaccharide vaccine. So it's literally they have taken the polysaccharides and they have put it in there. So Pneumovax 23 has 23 different serotypes in there. We also have pneumococcal conjugate vaccine. These are vaccines that are conjugated to a protein to improve immunogenicity. And there are currently 4 of them on the market. So PCV13, which targets 13 serotypes, PCV15, PCV20, and PCV21. Now, in contrast, we have meningococcal disease, which essentially means meningococcal meningitis. And this is due to organism Neisseria meningitidis, which is a gram-negative coccus, so it's very different than Streptococcus pneumoniae. And similarly, it has different, because it has a capsule, there are different serogroups. There are 12 serogroups that are known. Worldwide, serogroups A, B, C, W, X, and Y cause invasive disease, whereas in the US is more likely to be serogroup B, C, and Y. And there are different vaccines on the market. So, for example, there are the ones that target serogroup A, C, W, Y. There are some vaccines that target only serogroup B. And more recently, we have vaccine that targets all 5 of these that are most commonly causing disease. So if somebody wanted to prevent the risk or reduce the risk of developing meningitis, essentially because there are 2 organisms that cause meningitis, they need vaccination against Streptococcus pneumoniae, so pneumococcal vaccine, as well as vaccines against Neisseria meningitidis, so meningococcal disease. Now, when we give pneumococcal vaccine to people, so for sure, we are trying to prevent pneumonia, but more importantly, it is also reducing the risk of developing meningitis. So that's something important to keep in mind. In fact, when Streptococcus pneumonia causes invasive disease, typically pneumonia, which can be non-bacteremic for the most part, but some of these can be bacteremic pneumonia. So, when you have bacteremia, it can make it throughout the body, and when it makes it to the brain, you will have meningitis. So these are relatively less common, but certainly more fatal. Now, as of this recording, there are 5 pneumococcal vaccines available on the market. The first one is the Pneumovax 23. So this is targeting 23 different serotypes, and it is approved for age 2 years and older. These are essentially all of them 0.5 ml intramuscular injections, but Pneumovax can also be administered subcutaneously, and they all need to be stored in a fridge. So refrigeration is required, but not freezing. Prevnar 13 targets 13 of these serotypes. Then we have Vaxneuvance, which is PCV 15, Prevnar 20, which is PCV 20, and Capvaxive, which is a PCV 20. Now, with the exception of PCV 21, they're all approved for adults and children. And the PCVs, which are pneumococcal conjugate vaccines, differ from PPSV, which is polysaccharide vaccine. They're essentially conjugated to CRM197 carrier protein. So all 4 of the PCVs are, that's how they are conjugated, and that improves immunogenicity, which I'll explain in a minute. But also another thing to keep in mind that PCV 13, 15, and 20 also have aluminum in them as an adjuvant to further enhance immunogenicity. The latest one that has come to the market, PCV 21, does not have this adjuvant. So that's something to keep in mind, and I'll mention that shortly. Now let's take a look at which serotypes they cover. So you can see that PPSV 23, which is the oldest one, covers 23 different serotypes. And again, keep in mind that there are over 100 different serotypes. So essentially, we're trying to target the ones that are more likely to cause disease. Now, PCV 7, which is no longer on the market, targeted 7 of these that are also included in PPSV 23. In general, the response from PPSV 23 is not great. That's why we are trying to have different PCVs, and it's more difficult to create PCVs because they're conjugated to protein, and proteins are much larger molecules, so they're more difficult to include as many serotypes as possible in a single shot. So over years, we have seen the evolution of these PCV vaccine. So PCV 13, which is still on the market, covers 13 of these. PCV 15 added 2 more to PCV 13, and then PCV 20 added even more to PCV 15. Now, one thing that's interesting, the latest one, which is PCV 21, is not necessarily adding to the previous one. So it has it actually excluded some of the ones that they think are no longer causing disease because of years of vaccination and herd immunity. But they have introduced a bunch of new ones that are causing disease in adults specifically. So the previous ones were specifically targeted at children, whereas PCV 21 is more designed for adults. And here's what I mean. So when you see in this, we're looking at different age groups. So we're looking at what percentage of invasive pneumococcal disease is due to specific serotypes. And the blue is what's included in PCV 20 but not in PCV 21, whereas the gray is included, is common in both PCV 20 and PCV 21, and then orange is included in PCV 21 new and is not in PCV 20. So when you look at this, for example, in adults, you can see that somewhere between 54 to 62% of invasive pneumococcal disease were due to serotypes that were included in PCV 20. But when you look at PCV 21, that actually improves it. So somewhere between 77 to 85% of invasive pneumococcal disease cases in adults are actually covered by PCV 21. So that's why PCV 21 was designed to improve essentially prevention of pneumococcal disease in adults specifically. Now, let's take a look at some of these vaccines. So PPSV 23, which is the oldest one on the market, came to the market in 1983. Because it's pneumococcal vaccine, it does not depend on T cells. And because, infants or toddlers under the age of 2 have not matured their immune system, you're essentially not going to have immunogenicity in age under 2 years. So PPSV 23, for that reason, because it does not activate the T cells, it is not used for under age 2. Now, this does cover 23 valents, and essentially the studies have never shown that it can actually reduce the risk of pneumonia, but certainly it can prevent invasive pneumococcal infection, specifically meningitis. So there is certainly value in administering it to people. And then PCV13, which is the better formulation, so it's conjugated, so it has enhanced immunogenicity that depends on T cell, and for that reason it does work in children under the age of 2, so it's approved for anyone 6 weeks old and older. So it's part of, or it has been part of childhood immunization schedule. And in fact, it came to the market for children first before it came to the market for adults since 2010. And it has been proven to prevent not only meningitis but also pneumonia. So PCV13 is definitely more valuable than PPSP23, but because it only covers 13 serotypes, they definitely need to be administered in combination, not necessarily at the same time, but I'll go over the schedule shortly. Now, the new pneumococcal vaccines, so PCV15, 20, and 21, have come to the market in the past few years. So since in 2021, we saw that PCV15 and 20 came to the market for adults first, followed by approval for children. And PCV21 currently is only approved for adults. Now, these are essentially come to the market based on immunogenicity data. So we don't have efficacy data for any of these. So in other words, nobody has done studies to show that they can prevent pneumonia or meningitis. What they have done is to show that they can trigger the immune system to have antibody response against these serotypes that are included. So PCV 15, 20, and 21, they all have shown that they can have robust immune response. Now, here's what the CDC recommends when it comes to using these vaccines. So essentially, in a healthy person, so person with no comorbidities and person who has not received a PCV vaccine in their life. And I say that because nowadays PCVs are part of childhood immunization, but they didn't always exist. So there are a large portion of the population did not have these vaccines when they were children. But nowadays children are receiving these as part of their childhood immunization. So for people who have not received this as part of their childhood, for ages 19 to 64, for a healthy person, there's really no need for these. Now, once these people turn 65, they do need to get vaccination against pneumococcal disease. Because of high risk of mortality when it comes to pneumonia and other invasive pneumococcal disease. So they can essentially get any of these PCV, but it's important to get the PCV. So remember, PCVs are more effective than PPSV. So they can get either PCV 15, 20, or 21. So any of them are recommended with no preference over one or another. Now, the caveat is that if the patient did get PCV 15, they do also need to get a PPSP 23, just because 15 is not covering as many serotypes as possible, whereas 20 and 21 cover a large variety of serotypes. And here's the timing. So the timing is because PCVs are more effective, they should always get that first. In the case of 20 and 21, there's no need for PPSV anyway, so that's all they get. So either PCV 20 or 21. However, if the patient did get PCV 15, a year later, they will get a PPSV 23. And it's important to note that PCV and PPSV 20 should not be co-administered at the same time. So there needs to be some time between them. In this case, for healthy persons, at least 1 year. Now, in case somebody had received PPSV 23, again, because PPSV has been on the market since the 80s and these vaccines are relatively new, you could come across people who had previously received PPSV 23 a few years ago, and now they're interested in these new vaccines. So there needs to be at least 1 year apart between PPSV 23, and they can get pretty much any of these. So PCV 15, 20, or 21. With no specifically preference, for one over another. Vaccine doses do not need to be repeated if they were given before age 65. In other words, in healthy persons, they don't need to get vaccinated before age 65. They do after 65. But in case somebody, you know, went ahead and got it, let's say at age 60 or age 55, you know, by the time they turn 65, there's no need to repeat it. As long as they have got this at some point in their life, that's what matters. They will be protected once they turn 65. Now, when PCV15 is used in those with history of PPSV23 receipt, it need not be followed by another dose of PPSV23. So in other words, if somebody had PPSV23, then got PCV15 when they turn 65, you know, they're complete. There's no need to wait another year to give another PPSV23. Now, let's take a look at people who have other conditions. So it's good to think of three different groups. The first one is immunocompetent persons who have comorbidities, and that includes alcoholism, which the CDC defines for females having 4 or more drinks on an occasion in the past 30 days, and a drinking occasion is considered to be approximately 2 hours long. And for males having 5 or more drinks on an occasion in the past 30 days. And the next one is chronic heart disease, but not hypertension. So there are things like heart failure, chronic liver disease, such as cirrhosis, chronic lung disease like COPD, cigarette smoking, and diabetes. For these people, you know, prior to age 65, between 19 and 64, it's required for them to receive a PCV vaccine. So is there PCV 15, 20, or 21? And if it's PCV 20 or 21, there's no need for PPSV 23, just like healthy people. But with PCV 15, they do need to get the PPSV 23 a year later. Now, the next two groups are more severe conditions. So the first one is CSF leak and cochlear implant, but immunocompetent. And then the third group is immunocompromised persons. So these are people with asplenia, people with cancer, chronic renal disease, HIV infection, immunodeficiencies, sickle cell disease, and solid organ transplant. For these people, again, it is important for them to get the PCV vaccine prior to age 65. So either PCV 20, 21, or PCV 15. And of course, with PCV 15, they do need to get PPSV 23. What's different with these two groups is that because their conditions are more severe, you may consider giving that PPSV 23 sooner. So instead of waiting a year to give that PPSV 23, an 8-week separation can be considered for PCV 15 to give them that extra coverage as soon as possible. And it says it's considered because you know, you might get insurance issues. So this is a matter of whether you know, you can get the insurance to work or not. Now, in case people had previously received PPSV 23, they do need to get their PCV at least 1 year apart in order to get full protection. Now, because PCV 13 has been on the market for the longest time, the question is, what do we do for people who had previously completed their immunization schedule? You know, so specifically for age 65 and older. So they had completed, they got their PCV 13 and they got their PPSV 23. And these vaccines, the other ones were not available at the time. So they finished. What should we do now? So this is essentially a shared clinical decision making. So, you know, you can discuss with the patients potential benefits of these vaccines. And if their insurance covers it, for example, or if they're willing to pay out of pocket, you know, they may receive PCV 21 or PCV 20 at least 5 years after that PPSV 23. And PCV 15 is not on this because those two extra serotypes is probably not worth the trouble. But PCV 20 and 21 give enough additional serotype that you know, they may be considered as part of shared decision making. And for those other patients who have you know, indications for getting the vaccine before age 65, you know, the same. So if they had received PCV 13, they may get PCV 21 or 20, you know, at least a year later. And for those who had received PCV 13 and they completed it with PPSV 23, and back in the days, some of these immunocompromised patients actually needed to get 2 PPSV 23s after PCV 13. So regardless, if they have completed it by the time they turn 65, they can get either PCV 21, 20, or get another PPSV 23.